Yeah? Can I talk? Hi, I'm Dr. Moalemi from Amelia Heart and Vascular Center, and today I'm going to be talking to you about atrial fibrillation. So atrial fibrillation is an arrhythmia of the heart, it's an irregular heartbeat. But in order for you to understand atrial fibrillation, you have to understand a little bit about how the heart works and how the electricity of the heart works. The heart is a very powerful muscle. It's a very coordinated and intelligent muscle that you cannot control. When I want to move my hand, there's a single axon from my brain to my finger, and when I command my finger to move, I move it. But I am not in control of my heartbeats. So approximately every second, I have a single heartbeat. How is it that that happens? Well, that's because the electricity of the heart is embedded inside the heart. And I'm going to do an illustration for you. So as I just showed you, the heart has 4 chambers. And there is a right atrium, a right ventricle, a left atrium, and a left ventricle. In the right atrium, there is a conglomerate of cells called the sinus node cells. These cells exchange ions, potassium, sodium, and chloride, in such a ratio as to create a microampere of electricity that basically goes from cell to cell, from the beginning of the heart, from the right atrium, into the middle of the heart, an area called the AV node, and then propagates across these cells in 2 bundles of fibers called the Purkinje fibers. We have a right bundle and a left bundle. When the activation starts in the sinus node, we get a little blip on the EKG called a P wave. And then when it reaches the AV node and it starts propagating, you get the QRS complex. When the heart contracts, it's called in the ST segment, and then the heart relaxes, you get the T wave. Then the process starts all over again. And that's why you have a very regularized rhythm. This rhythm is called a normal sinus rhythm. It's normal because it's normal. It's sinus because it starts from the sinus node. Now, when you're nervous, when you have to exercise, when you're dehydrated, this has to happen, but faster. Your heart needs to work harder. So the process happens exactly the same way, just faster. And this rhythm is called sinus tachycardia. So your heart rate can go faster than 100. On the average, your heart rate can go from 100 all the way to 220 minus your age. So if you're 40 years old, your heart can go as fast as 180 beats a minute. Now, when you're sleeping, you need a slower heart rate. And the same thing happens, but just much slower. And that's called sinus bradycardia. Sinus tachycardia, sinus bradycardia, and normal sinus rhythm are all normal rhythms. Now, it turns out there are centers on the top chamber of the heart, an area called the left atrium, where pulmonary veins drain, where cells can become active out of no good reason at all. And these cells start sending impulses to the middle of the heart at much faster heart rate than the heart can handle conducting. So as these cells bombard the AV node, you get all these little blips of P waves, and then the AV node will only conduct as fast as it can. So it will try to conduct as many as fast as it possibly can. And so you get these P waves and these QRSs that are not equidistant, and as a result, you have an irregular heartbeat. This is atrial fibrillation. Pardon the handwriting, but you get the point. So the top chamber of the heart is beating out of synchrony with the bottom chamber of the heart. What's the problem with that? When the top chamber is beating so fast, it's actually fibrillating. When the top chamber fibrillates like that, then blood becomes stagnant in that area, into the left atrium, in this area, and forms clots. And clots then travel to the brain and cause a stroke. So the risk of atrial fibrillation is mostly the risk of a stroke. Now, not everybody with atrial fibrillation has the same risk of a stroke. We use an algorithm called CHA2DS2 score to decide what your risk of having a stroke is. CHADVASC2, CHADVASC2 score is a mnemonic we use to decide to basically figure out what your risk of a stroke is. C stands for congestive heart failure, H for hypertension, A for age greater than 65 or age greater than 75, D for diabetes, VASC for vascular disease or coronary disease, and 2 for being a female. So the more of these risks you have, the more likely you are to have a stroke from atrial fibrillation. Say you are an 84-year-old woman with atrial fibrillation. Well, you have the number 2, so that's 1. You're older than 75, so you get 2 points for that. And let's say you have diabetes, so now your score is 4. If your score is 0, your risk of a stroke with A-Fib is about the same as the general population. If your score is 2, your risk of a stroke is 2.5% per year. With a score of 3 is about 4%. With a score of 4 is greater than 5%, and so forth. The American College of Cardiology recommends that any patient that has a score of 2 or greater has a prohibitive risk of a stroke and should therefore be taking a blood thinner. So if your score is 0, usually we don't give you a blood thinner. If your score is 2, we start you on blood thinners. And if your score is 1, then they leave it at the discretion of the physician with discussion for the patient. For example, say you are a woman and you're 64 years old. Well, your score is 1, but you're almost 2. And so therefore we would err on the side of giving you blood thinners. I wanted you to understand why we give blood thinners to patients who have atrial fibrillation. Now, many patients are very apprehensive about taking a blood thinner, and that's quite understood. However, remember, if you have a stroke, we can't do anything for you. There is no cure for a stroke. And when people have a stroke from atrial fibrillation, they're not funny strokes. They're not like a little, speech impediment. These are biggest strokes. Part of the body is paralyzed. You can't see, you see double, you have balance problems. And these are lifelong problems. When you take a blood thinner, you reduce your risk of a stroke substantially. You have to understand there's potential risks of a blood thinner, but those risks are usually substantially lower than your risk of having a stroke. So discuss those risks with your doctor. Do not be too antagonistic to the possibility of taking medications that are advised for you, and make an informed decision. Thank you.